Hello, good evening everyone, and welcome to 365 Live. A gentle reminder that all information shared at this event by the speaker and 365 CPS is for general information only. Do consult your doctor for personalized and detailed medical advice if needed. Alright, so without further ado, I'm pleased to introduce tonight's speaker, Dr. Lee Kaiman, a consultant radiation oncologist at Farrer Park Hospital. So, Dr. Lee is a practicing radiation oncologist with about 30 years of clinical experience. He received training in the US and UK and has been treating patients with advanced radiotherapy techniques. Prior to Farrer Park Hospital, Dr. Lee was a senior consultant, head of department, and acting clinical director at the National University Cancer Institute. And he is currently a visiting consultant at National University Hospital. He holds leadership appointments in professional and academic bodies in radiation oncology. So tonight, he will be debunking myths and addressing misconceptions around cancer. So please, if you have any questions, please feel free to post them in the chat, and Dr. Lee will address your questions during the Q&A later on. So let's take a look. Do we have Dr. Lee online with me right at the moment? Hello, Dr. Lee. Hi. Thank you so much for joining us tonight to share your knowledge with everyone. All right, let's hit right into the topic for tonight: unmasking cancer, debunking myths, addressing misconceptions. Onward to you, Dr. Lee. Thank you.
Thank you once again, the organizers, for inviting me to give this sharing. And thank you, one and all, for being present on this very precious Saturday evening. But obviously, cancer is interesting enough and perhaps sobering enough a topic for us to turn up. And tonight, we are specifically talking about some of the possible misconceptions and myths out there. And along the way, I'd like to address what is the general approach, our general approach in the management of cancer. I gave a talk almost similar a few weeks ago on this platform, and that was specifically on prevention and screening for cancers. And so there might be some overlap for those of you who were present previously. I'd like to begin with these slides. So as I said, cancer is interesting and at the same time a very sobering topic for us to want to come to this talk. For us in the clinic, it presents in a various of ways. So you see on this screen different images. So on the top left, you see a chest X-ray of an obvious lung cancer on the left lower lobe near the heart. And then below that, you see the colonoscopic picture of rectal cancer, right, with the irregular surface and a bit of dried blood there and an obvious mass. Then right in the center, you see an MRI picture of a patient with metastatic brain cancer. In other words, the cancer originated in some other source, whether it's a lung or breast, as it is common, and then somehow finds its way to the brain, presenting in a few spots shown on the MRI. And on the right-hand side, you see a PET scan picture of the bony skeleton, again showing up disseminated cancer, evidenced by all these dark spots you see along the spine in the middle. So cancer, when it comes to, when it presents itself at the clinic, can come in different versions, different presentations. Therefore, leading to some possible misconceptions, some confusions, and perhaps there are more, but just to highlight three common ones. So when one is struck with a cancer, when a patient presents in the clinic, one common question that is being asked is, why me? Am I the odd one out, right? Then another common question is, or misconception is, does this mean there's no cure, no hope? And the other one, which is quite real, is, does this mean unbearable, uncontrolled pain and suffering, either from the cancer itself or the treatment with the attending side effects? So these are all relevant and valid queries, questions that when one is afflicted by the disease, that commonly expresses itself. These questions commonly express. So along the way, I try to address some of this. Am I the odd one out? Not so. If you look at this statistics given by Singapore, local statistics given by MOH, over the last 20 years, from 1997 to 2015, in fact, not the last, but even earlier, over a 20-year period, you see a basically doubling of the cancer rate from about 6,000 plus to about 12,000 plus in a space of 20 years. So the incidence of cancer is indeed rising. And in an ultra-aging society like Singapore, all the more it becomes evident. If you look at the stats a bit more detailed and more recently reported, this is up to 2022, just look on the right-hand side, there's actually been a 3 to 4 times increase in incidence over the last 50 years. And this translates into a 1 in 4 person lifetime risk of developing cancer. So certainly not that rare, fairly common, right? And this is just a slide for reference to highlight the commonest cancers. In men, the commonest is prostate, followed by colorectal, and then lung. For females, it's breast, colorectal, and then lung. All right. In fact, there's a slight female preponderance over men. Having said that, it's encouraging from this slide to know that some of these cancers are in fact preventable. This publication put up by the American Society of Cancer actually spells out that up to 40% or 40% or more of the cancers that we see in the clinic are actually preventable and within our control. And this is because the common causes of cancer are lifestyle issues related to, for example, smoking, obesity, diet, alcohol, radiation, physical inactivity, and again, dietary related factors. So if we want to be intentional about it, if we want to be conscientious about it, the American Cancer Society projected that up to 40%, which is a good figure, right? 40% of the cancers that we see today can actually be completely prevented. So that's the encouraging takeaway from this slide. So how do we then go about maximizing the prevention? Obviously, we work on the causes. So if, as I said just now, if we make some intentional lifestyle adjustment with regards to the use of tobacco, smoking, alcohol, diet, obesity, and physical activities, that will help. If we know about the specific type of infections that can cause cancer and we introduce some vaccinations like hepatitis, human papilloma virus, HPV, or antibiotics for certain bacteria, that can again reduce the risk or prevent the formation of cancer. Now, this is the one that's a bit tricky. In about 5 to 10% of cases, the cancer genes are passed down in a hereditary fashion. That means from grandparents to parent to children. So in that sense, unavoidable for that small group of patients, 5 to 10, but yet again preventable if that his family history is known, picked up early, and the relevant individuals go for the right counseling, and where preventive surgery can be taken early on. For example, for BRCA1 and 2 genes for breast and ovarian cancers, that can actually prevent the cancer from expressing later on in life. So there are preventive measures even in genetic and hereditarily disposed cancers. And of course, as alluded to earlier in the introduction, early detection by screening for early stage cancers, or even better still, pre-invasive stage cancers, can again prevent the cancer from forming. And this applies to two groups of people. One is the general public, what we call mass cancer screening programs, and those with high risk factors. All right, those families that have a higher incidence of cancer among family members. So these are overall strategies that we can adopt to try to target that 40% reduction. So in Singapore, I made this point earlier in the talk a few weeks ago, we are actually very privileged to have a very responsible ministry, and also supported by certain proactive agencies like 365 Cancer Prevention Society, like Singapore Cancer Societies, like HPB, Health Promotion Board, where comprehensive screening programs are in place. All right, for example, you look at the left-hand side, mammogram for breast cancers, PEP test for cervical cancers, HPV screening again for cervical cancers, and fecal blood testing and scopes for screening of colorectal cancers. These programs are readily available in Singapore, and they are targeted at different age groups. For example, at a very early age for females, at 25, you can start going for this PEP scan, PEP smear screening, and then up to 40, and then from 50 and above, screening is available for colorectal cancers and breast cancers. So they're readily available and heavily subsidized, if not free completely. All right. So, for example, cervical cancers, you see in this slide, 25 to 29 years, what is recommended is a PEP test, a PEP smear screen once every 3 years, probably once or twice. And then after that, once you're past 30 years, once in every 5 years, a HPV screening test, all right, for all Singaporean women. Some pictures how this is done. PEP smear, all right. So what we try to do is basically to pick up very early stage of pre-invasive cancer where the cervix look normal before there's any telltale signs of an early cancer, intermediate stage, or even a late stage. So we do a brushing of the cells there and send it for testing, what we call PEP smear, before the cancer is evident like this in an MRI. All right, this is a huge, bulky cervical cancer on the side profile of patient's pelvis. This is the uterus, and this is cancer at the bottom of the uterus. So that's for cervical cancer. For breast screening, again, these are mammogram pictures. Before the cancer is obvious, a normal mammogram. Then when it's a benign cyst, not cancerous yet, that's when you need to pay some attention. And then when it becomes a cancer, it needs to be taken out. So there are different sort of scales, a whole spectrum of findings, but what we zero in on those right in the middle, which is sort of neither here nor there. But if you pick it up early, there's actually a 2 to up to 95% risk of cancer. And obviously, if you can pick it up at that early stage, the prognosis is much better, all right, than if it is later. So that's breast. And colorectal, when it presents first as a polyp, all right, way before it becomes a tumor like that, all right. So those are the three common cancer screenings that are available in Singapore: cervical cancer, breast cancer, and colorectal cancer for the general public, all right. Then for certain patients, certain individuals who are considered at high risk, especially if there's a family history, like for example, liver cancer, where a patient is a hepatitis B carrier, all right, then you can go for screening, some blood tests for this marker called alpha-fetoprotein and a liver ultrasound every 6 monthly. For those who are heavy smokers, there's this thing called low-dose CT lung that can be done yearly to pick up early stage lung cancer. Family members of NPC patients, nasopharyngeal cancer patients, first-degree relatives, are strongly recommended to go for a blood test, a EBV detection, and a nasal endoscopy to make sure that there's nothing in the nasopharynx. And patients who are elderly men who are elderly as in sort of 60 and above, with first-degree relatives of prostate cancer, are encouraged to go for a blood test to pick up to assess the blood PSA level, prostate-specific antigen level, at least yearly. So these are for high-risk groups. And of course, as I said, if we know of certain cancers that are caused by infections, there are effective vaccination in place. For example, for HPV virus, there are two types of vaccination that are recommended for women for different age groups. For example, 9 to 25 and 9 to 45. Again, these are readily available in Singapore. So those are all, what I've shared so far is really on cancer prevention. And if you do those well, as reported, we can actually prevent 40% of the cancers that we see today in the clinic. But what if cancer still appears? All right. So I was asked this question at the last talk. So what are telltale signs to pick it up early? So I thought I'll just put in a slide to quickly address this for those who are anxious about this, who are particular about this. So the telltale signs are variable, but this is a common list. So from the beginning, if there's a lump or swelling unexplained anywhere in the body, especially in the breast for women, detected perhaps during a shower, do have that looked at by your GP first. And then if there's any unusual bleeding or discharge, whether it's via the urine, stools, or PV, that means per vagina, if there's any spotting or bleeding or discharge, do have that looked at. If there's any unusual change with bowel that doesn't go away, for example, extreme bloating, constipation, diarrhea, change in the stool color or form, or changes in the bladder, urine color, difficulty, frequency of passing urine, again have that looked at by a GP. If there's any cough or hoarseness, voice hoarseness that doesn't go away for protracted period after, say, 1 or 2 courses of antibiotics. If there's pain, again, that doesn't go away, whether it's with some painkillers, some rubs that you have applied for a couple of weeks that doesn't go away, again, it may be a telltale sign. If there's any unusual weight loss for no reason, of course, if it's intentional, you've been going out to the gym to work out, that's a different thing altogether. And then skin changes, if there are any bruising, a lump, again, that bleeds or turns scaly, some change in a skin mole that has been there for many years, but recently some change in character. These are telltale signs. To put in perspective, most of the time, all this leads to a non-cancer situation. It's probably caused by some infection, some inflammation, some strain, some sprain, some aches, some infection. But as I said, if it persists or it gets increasingly more severe, then that's the time to have it looked at. All right. So to put in perspective, most of the time, these are common symptoms. If they go away after a short period of time, after some initial treatment with painkillers, antibiotics, then well and good. But if they persist, they recur, they get more serious, then they need to be looked at. So when we are highly suspicious of cancer, let's say all those signs and symptoms that I mentioned earlier persist, what do? Then you need a diagnosis. After the diagnosis and the confirmatory test is a biopsy, followed by some X-ray scan, CT, MRI, PET scan, all right. And then we do a prognostication. That means how early is this disease, how advanced it is. We take into consideration also the patient's age, whether they're young, whether they're elderly, and whether there are any coexisting medical condition. We define the tumor stage, and then the definitive treatment will be recommended, all right, whether it's surgery or something else, all right. And once after the treatment is done, then a follow-up surveillance of the patient. So this is the general outline of how cancer is managed in the clinic by the different specialists. Some pictures, all right. So this is an NPC, a nasopharyngeal cancer. On the left here, you see the MRI showing a very not so obvious, but you see some irregular on the nose, internal nose, the posterior wall or the back wall of the nose. If you do a PET scan, it lights up here, this orangey color here. This orangey color is part of the brain, so that's background. That's not cancer, but this one in front is cancer. All right, and further down the neck, this is the chin area. This is the chin, the jawbone. All right, just next to it on this side, you see this mass here. That's a lymph node. A bit here, not so evident, but on the PET scan, that's picked up. All right, so this is an MPC picked up on MRI and PET scan. This is a tongue cancer. Likewise, this is an MRI, a bit of irregularities see on this side. This patient probably had some difficulty swallowing, some pain at the edge of the tongue. And then when a PET scan is done, you see all this. This is where the primary tumor is. And these are the lymph nodes, all right? Again, barely can just see on the MRI. Unfortunately, this patient has got also cancer that's spread from the tongue down to the lung area. All right, this is the lung. You can see the lungs on both sides, and then the lymph nodes around the lung. So the cancer is spread from the tongue all the way down to the lungs. All right, so this is an advanced stage of cancer, picked up a bit more later than it should. Cancer treatment. So I mentioned this also. Does it mean that there's no cure? Obviously, that isn't the case. All right, with current treatment, many cancers are curable, all right? And different options would include surgery, where the cancer is removed and the affected lymph nodes, as we saw on the scans, will be removed. And then we add on radiation for about 60% of these patients most of the time to sort of give the additional protection, all right? We also very often combine that with systemic therapy, including chemotherapy, hormonal and targeted agents, immunotherapy. Very often, as I said, a combination of this, either two out of the three or all three may be used, depending on the type of cancer, the stage of cancer, the aggressiveness of the cancer. So a multidisciplinary approach involving tumor boards are commonplace these days, all right, in the management of cancers. So I'm a radiation oncologist. So just a few slides on the radiotherapy. This is a modern day radiotherapy machine. All right, patient lies here. The machine spins around the body to give the radiation. Common schedule is about 5 days a week, consecutive. We can do this for curative intent, in addition to surgery, or sometimes just to relieve symptoms if the cancer is very advanced, what we call palliative treatment. The schedule depends on the intent. The longer it is the more curative it is. Shorter it is, very often is to relieve pain. There's this form of very high precision radiotherapy called stereotactic radiotherapy, which is just 1 to 5 fractions, 1 to 5 sessions. These are often used, as I said, in combination with chemotherapy or targeted therapy or immunotherapy. This is a picture on head and neck radiotherapy where we put a mask on, and this is that NPC patient that's treated, the nasopharyngeal cancer, where we treat the primary as well as the neck that's affected. So the nose here and all the way down to the neck, more so on this side, but also some dose on the right side. I'll speed up a little bit. So just to give some encouragement, so this was the original cancer that we treated, and then after the radiotherapy, this is combined with chemo, concurrent chemo radiation, that's all gone, all right? And then the neck nodes here that you see, that we saw earlier, that's also gone after the treatment. So as I made the point earlier, with modern medical advancement, many cancers are curable and there is hope, all right? This is another example of prostate cancer. So you see this spot here on a PET scan on this gentleman's prostate. After 20 fractions of radiotherapy, you don't see it anymore, all right? This one is a patient with a lung cancer patient with a brain metastasis. You see the spot here. And then after that, we took this patient to treatment. We give that stereotactic, that short course, high precision radiation. And after that, we repeated the MRI and that's gone within a couple of months, right? This is July, November, about 5 months, tumor is gone actually. So basically, with aggressive treatment, whether it's surgery or radiotherapy, to take out the tumor, to get rid of that tumor, there's a good chance that the patient can be cured. In addition, systemic therapy is usually involved. All right, this is commonly in the form of chemotherapy. These are anti-cancer drugs that are given over a few months, about four to six cycles, all right? And usually about 3 to 4 weeks per cycle, all right? There are some side effects like hair loss, nausea, vomiting, loss of appetite, risk of infection, and all that. This chemotherapy, again, just to emphasize that this systemic therapy is injected into the body and it goes all over the body, unlike surgery or radiation, and it can affect both normal cells as well as the cancer cells, hence the spectrum of side effects, all right? So something that we want to be very attentive and careful about as well. Now, this is another form of systemic therapy, immunotherapy, which you probably have been hearing more and more in the news. This is more recent. I think it's been introduced in the last maybe about 10 years, 5 to 10 years, whereas chemotherapy, radiotherapy has been around for 30 to 50 years. All right, this is more and more being used in the sense that it targets cancer in a different way. Basically, it activates the patient's own immune cells to make sure that to enable them to be effective against the cancer, all right? I won't go into the details, but again, we are also concerned on the flip side about some of the side effects that are possible, all right? So, and then you may hear about targeted therapy, another form of systemic therapy that targets certain specific receptors and blockers in the body cells, all right, in the cancer cells in the body, sorry, all right. So there's a whole range of it. No time to go into all the details, but there are different targets that are being discovered by scientists, medical science, and each of them is being exploited as a target that these new agents, monoclonal antibodies, can actually seek out and get rid of the cancer cells. Regardless of whether it is chemotherapy or radiation therapy, as I kept mentioning, as much as we want to get rid of as much of the cancer as possible with each dose, we are also mindful of the flip side, a list of side effects that are possible with both chemotherapy and radiation. So along the way, over the years, fine-tuning is in place to make sure that while the intent is still to take out the cancer cells as much as possible, every effort is made to reduce the side effects as much as possible. So for example, again, radiotherapy, you can see that for left-sided breast, all right, it's very near the heart. What we do is we use some elaborate technique to try to separate the heart from the breast so that the radiation can be given safely, so sparing any potential or reducing the risk of any potential side effects on the heart. All right. Likewise, for radiation to the pelvic area, in the past, radiation is given as a big box like that, affecting both cancer cells and normal tissues in the area. But now with modern technique, we are able to shape the radiation to such a way that we can just target the cancer cells and avoid the normal tissues in between, all right? The point is that fine-tuning is being made. This is another example. This is a tumor of the bone here. In the past, it was just front and back treatment. So everything along the way of the beam of the radiation will get the same kind of dose. But with newer techniques, stereotactic radiation therapy, you can actually conform the tumor around the shape of the conform the radiation around the shape of the tumor so that it's more precisely delivered, and it reduces the spread, reduces the risk of side effects all around. Okay. Having said that, I have spoken quite a fair bit about surgery, radiation, chemotherapy, immunotherapy. All these are anti-cancer treatment, all right? Just as important, if not more important, is a supportive care, which plays a large part in actually overcoming the fears, overcoming the discomfort, the pain, and the suffering that's associated with cancer. So as much as all this is taking place, all this should be given maximum attention with regards to pain control, antibiotics for infection, steroids to reduce inflammation, physiotherapy. There are a nutritional program, complementary medicine. So all these again are available in many of the cancer support agencies, not least 365 Cancer Prevention Society. All right, you probably hear more about this later. And then complementary therapies, like for example, exercises, a bit more controversial, but they are actually listed in some of the major cancer centers worldwide. So they have a place as part of the holistic management to cancer care. Okay, coming to the end. So in summary then, cancer, dreadful, it can have an adverse effect on all of us, not just the patients, but the loved ones supporting them, not only physically, but also mentally and emotionally. However, medical advancements have been made in major ways, involving surgical techniques, radiation techniques, the delivery of chemotherapy and immunotherapy. They've all contributed to an increase in the cure rates of cancer. Therefore, some cancers are preventable, many are potentially curable, and all are manageable in some ways. With that, I thank you for your attention.
All right, thank you, Dr. Lee, for your comprehensive and informative sharing and to debunk myths and address misconceptions about cancer tonight. So, for those who have just tuned in, I would like to share this again. So, if anybody has any questions, please feel free to share in the comments below, and we will invite Dr. Lee to address them accordingly. So let me give a brief summary about what Dr. Lee has mentioned tonight. So Dr. Lee has shared some common signs and symptoms about detecting early telltale signs about cancer. He has also mentioned that more than 40% cancer cases can be prevented and avoidable. So simply by working on lifestyle intentionally and working on having a balanced diet and taking food in moderation. So while some of you type your questions, let me see. We have a few questions coming in the chat. The first question that I spot, how fast does cancer usually spread?
So that's a tough question to answer actually, because as I made mention right at the start of my talk, the very first slide that I showed were different manifestation of cancers, right? So they can present in a very localized fashion, and some even at the very first presentation, it can be quite widespread. So, of course, most are somewhere in transit, all right? So when they present, it is localized, but later on in the months during the treatment or the follow-up, then we detect spread or recurrence. So it really depends on what type of cancer, which site, and even with each respective site, there are different levels of aggression, whether it's a high-grade tumor or a low-grade tumor. So by and large, a low-grade tumor will spread more slowly or never at all, which is good news, whereas a high-grade tumor tend to spread more aggressively, maybe within months, if not years.
I see. Okay. So talking about the cancer spreading, right? There's another question about why cancer can recur after surgery or treatment, Dr. Lee.
Okay, so as I said, the main treatment when a cancer is localized, let's say it presents in just one site, and it can be resected. It can be taken out by surgery. Then most of the time that would be recommended. Then after that specimen that is removed will be subject to quite intense evaluation in the lab. All right, to look at the aggressive nature, the size of the tumor, the extent of local spread already, even though it's confined to just region. And then if additional treatment is recommended, this is what we call adjuvant treatment. Surgery is already done, the tumor is already removed, but we feel that the patient is at considerable risk of a relapse. That's when additional treatments like radiotherapy, that's where I come in, to give that area around the originating tumor some radiation to neutralize that area a little bit so that to prevent or to reduce the risk of recurrence. That is commonly done, for example, for breast cancer. Now, in the past, some of you might know that in the past, maybe about 30 years ago, most breast cancers were treated by a mastectomy. That means the entire breast will be removed. But that has gone out of fashion. Now, 30 years fast forward, right, mastectomy is still done, but not so common. Most of the time, we talk about breast conservation surgery. That means we just remove the lump, not the entire breast. All right. We also test the lymph nodes to see whether there's a spread there. And then, based on those findings, we would then very often recommend some radiation in the region to, to minimize the risk of this coming back. Otherwise, short of a mastectomy, there may be a considerable chance of that tumor coming back again in the remaining breast. You see.
I see. Okay. And I guess there's quite a few questions coming in about the cancer recurring. So there's a question: can stress be the one that affects cancer recurring?
There are some studies, although it's not very sort of a concrete kind of link, but there's some studies that have suggested that stress levels, although it's hard to actually specify what are the markers, lab markers for stress, but there is some loose evidence, there thin evidence that stress can somehow, predispose to a cancer reappearing or recurring. All right.
Okay, and we have a question. The 80 year there is a 81-year-old mother needs to be put on protocol for long-term chemotherapy for urothelial cancer. So, what are the risks of having that protocol at the collarbone?
Okay, so like all procedures, Portocaf is like a foreign body that is in the body, right? And the purpose of this is to facilitate the chemotherapy in order to control the cancer. The flip side is that the Portocaf itself, as a foreign body, can actually be a potential source of infection, bleeding, and pain around the collarbone area. So careful nursing care will be needed to maintain that, to make sure that infection doesn't set in, and it doesn't get blocked. If it gets blocked, the tube gets blocked, then defeats the whole purpose of putting a tube there to facilitate the chemo. Then the whole tube will have to be removed to prevent any infection.
So careful nursing care
Yes,
is
yeah,
needed. Okay.
and the tube needs to be flushed often to prevent blockage.
I think we have a follow-up question on just now the breast conserving surgery. So, is there a higher chance of cancer recurring compared to mastectomy?
Okay, is there a higher chance of cancer recurring compared? So certainly, breast conservation surgery alone has a higher chance of recurrence compared to mastectomy. That in itself is probably a fair statement, especially if the cancer is is high risk, is aggressive, is big, all right, and the surgical margins are close, all right, then obviously the risk of recurrence is higher than a mastectomy, whereby the entire breast is removed. And that's the kind of situation where very often radiation is recommended, and it's been proven to reduce the risk of recurrence as close to that of mastectomy as possible. In other words, short of mastectomy, we want to have as low a risk of recurrence with the breast intact. We then recommend radiation.
All right, for those who have just tuned in tonight, I would like to share this once again. So, if you have any questions, please feel free to share them in the comments and we will invite Dr. Lee to share them accordingly. So, I see we have this question. There's an audience member, she mentioned that she was diagnosed with cancer at the womb. So, she removed ovaries and lymph nodes. So, the doctor suggests no further treatment is required. So she would like to find out what is Dr. Lee's opinion about this decision.
Okay, that sounds promising actually. So in general, of course, I do not know the details and it's probably inappropriate to discuss the details on a platform
Yes.
like that. But in general, for a cancer of the womb, the first major treatment is surgery, right? And if that is done completely, then after that, we will then, as I said, the specimen will be subject to close evaluation in the lab. All right, what we call the histology report, right? So based on the histology report of the of the womb, of the tumor, of the ovaries, of the lymph nodes, then we make an assessment of whether, broadly speaking, whether this is low risk, it is intermediate risk, or it is high risk. If the assessment is that of low risk, then good for you. No further treatment is required because we think surgery alone is good enough to get rid of this cancer for a good chance of a cure. All right. If, however, let's say at the other extreme where the surgical specimens after removal suggest that there may be some risk of recurrence that the doctor, the surgeon is not comfortable with, then the patient will be then subsequently referred to an oncologist, either a medical oncologist or radiation oncologist like myself, to make a recommendation whether additional adjuvant treatment is required. That means chemotherapy or radiation, or sometimes both. All right, depending on the risk stratification. So I take it that, as I said, without going into the detail, if your primary gynecologist feels that no further treatment is required, I assume that the risk is low, and there's every reason to be hopeful that maybe the surgery itself would be curative.
Mhm. Oh, talking about chemotherapy and radiotherapy, we do have an earlier question that one of the audience member asked. So, which is the better cancer treatment? Is it chemotherapy or radiotherapy?
Okay, so I rushed through this just now. I apologize for not making it so clear. So the first of all, the role of all of this surgery, chemotherapy, radiotherapy differs from cancer to cancer, patient to patient, stage to stage. So it can be a very complicated permutation, which is needed: surgery, or radiotherapy, or chemotherapy, or a combination of two, which two of the three, or all three together, and which one comes first. So it can be quite confusing. As to which is better, I can only say that, again, it depends on what type of cancer. For example, in the earlier example that was asked, if it is womb cancer, then it's very clear cut that the main treatment, the major treatment, before chemotherapy, before radiotherapy, would be surgery. No question asked. Surgery will be first. That would be the best treatment, so to speak. After that, then as I said, depends on the risk profile. We will then consider whether this patient needs chemotherapy or radiotherapy or both. It is not so much which is better, but which is needed more for that particular set. If I may just add, radiotherapy, that's what I do, is a local, regional kind of treatment. It is targeted. It is given and delivered to the cancer original site. For example, if it is the womb or it is the cervical area, then the radiotherapy is delivered to that area, all right, where the tumor is. Chemotherapy, unlike radiation, is systemic therapy. I think some of my slides showed that. In other words, it is injected into the body, it enters the body system. So it theoretically has the benefit of tracking the cancer cells throughout the body system. All right. So So you can see that if there's a risk of that cancer cell, if the doctors, the specialists, think that this cancer is at risk of spreading to other parts of the body away from the original site, then chemotherapy might be the most suitable treatment because it goes to the rest of the body system, whereas radiotherapy doesn't. But if the risk is more of a local regional risk, then radiotherapy will be more, will be more indicated because it adds onto the local control with surgery. And sometimes, as I said, if the risk is high enough, you may need all three: surgery followed by chemotherapy and radiotherapy. So they complement one another. So surgery, chemotherapy, radiotherapy, they act. They have complementary roles. They how should I say, they approach the cancer management from different perspective.
Okay. And also we I think we do have two similar questions. So one is about does genes affect how fast the cancer spreads in the body? And another question that is pretty similar is how does cancer spread from one organ to other?
Do genes affect how fast the cancer spreads in the body? Okay, let me try to tackle this one first. This one's a more of a biological question. Okay, all cancers, all cancers arise because of some problem in the gene. There is a genetic change. All right, but bear in mind, I want to qualify, it doesn't mean that this genetic change is necessarily passed down from a parent to the child. It may well, the parents may have that normal gene, but somehow that gene become cancerous. All right, that genetic change leads to a cancer within that patient, but that change wasn't passed down. It's not hereditary, but nonetheless, it's a genetic event. All right, so every cancer actually starts off from a genetic change. Something went wrong with the genetic control of how the cell behaves. That cell then starts dividing uncontrollably, and then it forms multiple cells. Then it forms a whole mass, and then the mass starts invading into the blood vessels, into the lymphatics, and that's where, to answer the other question, that's where the spread takes place. All right, then it goes from one organ where it started, and it travels in the bloodstream or in the body lymphatics to another organ that's far away, maybe in the lung, maybe in the bone, or in the liver, away from the original cancer, which may be, for example, in the womb. All right, so come back again to the question. So depending on that genetic change, if that genetic change is something that is more serious, a more aggressive one, then it may cause that potential to be more invasive, to be more widely spreading for that particular cancer. But if the genetic change is milder, then the cancer may tend to behave in a more local and less of a invasive fashion. So yeah, it boils down to the genetic change, and lots of studies now, lots of research now, and in fact, oncology is moving in a direction where you want to understand the genetic change, the basic change, and some of the genetic markers that may define that particular cancer, and then address that cancer and target the genetic changes to treat that cancer. So, in other words, if the genetic change is something that would suggest that this cancer might spread, if not now, then at some point, then you may be more proactive in treating the cancer, even though it hasn't spread. But if the genetic marker is something that suggests that no, this is quite mild, quite indolent, chances of spread later on is very low, then it may not be necessary to be so aggressive. So there is this idea of personalized, customized oncology care, which is very much the front line of cancer treatment. But it's still not really prime time yet. It's coming on where a personalized approach a more targeted approach is being adopted for the treatment of individual cancers and patients.
We have a follow-up question asking, so when cancer recurs, does it usually go to another part of the body? So the context is this. So for example, if the patient has breast cancer and completed treatment, when the cancer comes back, will it go to the same breast or does it go to another part of the body?
Okay, so if the cancer comes back in that same part of the body, let's say, for example, breast, if it comes back in that same breast, that's what we call a local recurrence. A local recurrence, and and just like the first time round, it will probably require the same kind of treatment because uh, it's like a representation of the tumor. All right, in the same form. But if the cancer now recurs not in the breast, but somewhere else outside the breast, all right, it may be in the lymph node, then it's what we call a lymph node recurrence. If it is in another organ, for example, the bone, then it's a bone metastasis. If it's in the liver, then it's a liver metastasis. So these are distant recurrences as opposed to the local recurrence in the breast or a lymph node recurrence that's nearby. So again, it is can be quite complicated as to what degree of spread the patient has, although a recurrence is detected, to what extent has it recurred? Is it a new area? Is it just one area? Is it a few areas? Or is it multiple areas? Is it multiple areas in the same organ? Or is it multiple areas in different organs? So these are, again, the different presentations and that we see among cancer patients in the clinic.
So tonight, Dr. Lee actually mentioned that working on lifestyle intentionally and having a balanced diet, taking food in moderation can actually help prevent cancer. So there's a question: are there foods which could actually ward off cancer? Any advice from Dr.
Yeah.
Lee?
So certainly, yeah. So I only mentioned three misconceptions like why me, and is there any cure or is there uncontrolled pain? But one common one which I get asked, what food should I avoid sugar altogether? Should I avoid meat altogether now that I'm diagnosed with cancer? Now, in my earlier talk, as a few weeks ago, I went into those details that certain food, certain diet is certainly linked quite strongly with cancer, with formation of cancer. For example, red meat, right? Red meat, animal fat, with certain types of cancer. But alcohol, for example, that too, right? But it doesn't also mean that if you avoid meat altogether, you will not get the cancer. It's again a risk management kind of thing. And I would go so far to say, as most dietitians will suggest, nothing extreme, but go on moderation, right? The occasional wine is okay, right? It's difficult to abstain altogether from alcohol completely, but not a daily kind of drinking, lah. If there's anything that should be avoided completely, it'll be tobacco smoking. So if there's one thing that we should avoid, either actively or passively, that has been shown to actually reduce cancer risk or prevent it altogether, it will be smoking. Food wise, I think just be moderate. Don't have to go on the extreme. Sugar, I mean, that's again because there's this idea that cancer cells are linked with sugar stimulation and all that. Well, I think sugar again should be if not completely avoided, should be controlled, should be curbed for other reasons, for diabetes, pre-diabetes, and all that. And so, yeah, a moderate diet on carbohydrates and sugar.
All right. Thank you, Dr. Lee, for answering and sharing so much with us tonight. So, just a few takeaways for tonight's sharing. So, more than 40% of cancer cases can be prevented and avoidable. So, having intentional lifestyle changes, having a balanced diet, taking food in moderation, avoiding tobacco, and trying to reduce sugar intake uh, does help maintain a healthy lifestyle. So thank you everyone for your questions and thank you Dr. Lee for your sharing. So it's now time for Dr. Lee to take his leave. So once again, thank you so much for sharing your professional insights, Dr. Lee. We have
Thanks for
learned
your
so
time.
much today. Thank you so much. So before we close tonight's session, do like, share, and follow us on our social media pages for the latest updates on our events. So once again, thank you so much for joining us tonight. I hope to see all of you in the next session. Please take care, stay healthy, and good night. See you.